We might start. Good evening, everyone, and thank you for dialing in to our very first Health Leadership Roundtable discussion with some of our faculty members. I might just quickly introduce a little bit about AIHE for those of you who may not be familiar with it, and then we'll get on with the show. So AIHE is the Australian Institute of Health Executives. It's a relatively new organisation that really just launched 5.5 months ago. So done an enormous amount of work to get to this point. What the reason for its establishment was really based on our experience in working in hospitals and healthcare. We saw the gaps that were still evident in terms of poor patient outcomes, clinical governance not being implemented from a practical perspective, and what was happening on the ground in terms of suboptimal healthcare leadership. So this arose out of a passion to actually make a difference in the health industry. And what we've evolved into now is an institute that has largely 3 arms that we deal with. First is very bespoke and relevant healthcare leadership development and training for all healthcare leaders, not just doctors, and at all levels of their career. The second is healthcare consulting, where we can review services, advice on clinical service planning and frameworks, etc., that are actually relevant for the health service. That's not just theoretical, but actually practical and useful. And the third arm is our thought leadership and industry analysis arm, which we have largely launched on our social media LinkedIn channel, but we are hoping to shift that onto our website soon. And this topic actually arose out of one of those posts. Now, we are an organisation that we call things out as we see it, within reason and with respect. But one of the key things that we saw was this concept of puppet leadership, which is what led to this whole thing being convened. So before I get too much into it, I might introduce some of our faculty there's a lot of our faculty, but there's three of our faculty who will be on the panel, who will be sharing their views and thoughts and experiences with us today, and hopefully telling us the answer of how to tackle puppet leadership in healthcare, at the end of 60 minutes. So please welcome Liza Collins, Dr. Mainak Majumdar, and Dr. David Quigley, who will be our panel. Now, Liza is a healthcare culture strategist and leadership development expert who has over 35 years of UK and international experience in health and healthcare systems. She's recognised for her pioneering work at the intersection of workplace culture, executive leadership, and system change. And I think she's up to her, 18th book, Liza? So she
Not
writes.
Quite there yet.
Yes, she's highly published, highly sought after, and we're lucky to have her here. So thank you, Liza, for joining us.
Thanks, Sidney.
Amy, can you just let the people, there's a notification about people coming. Okay. Dr. Mainak Majumdar is a senior intensivist with experience in emergency and retrieval medicine. He's very involved in research looking at the mechanics of healthcare systems, patient safety in hospitals, change management, risk management, and identification of high-performing health services. So that sounds like you do it all, Mainak. But thank you for being here, and Mainak will provide us with the clinical leadership lens in terms of how puppet leadership particularly impacts on a clinical level. And last but certainly not least, Dr. David Quigley, who is our faculty expert in health funding and coding analysis, who's also an experienced board director in the aged care, hospital and social care sectors, and is a leader in the development and delivery of digital health initiatives and change programs that are driven by data analysis to inform decision-making. So when he makes a recommendation, we know it's legit and it's based on data. So thank you, David, for being here, and welcome to the panel. What we might do is, for those of you who may have just joined us, So very briefly, the concept of puppet leadership in healthcare. Sorry, hang on. Lewis, you've got your hand up.
Yes, I'm sorry. I don't know who you are.
Oh, did I not introduce myself? Yikes. Apologies all. My name is Sidney. I'm the Chief Executive of, that's a good point. I'm the Chief Executive of AIHE. And the way that we'll run this session is obviously our expert panel will be sharing their insights and knowledge, and I will try my best to moderate and keep us on track. So puppet leadership, this all started with a post. If you haven't seen it, please go to our LinkedIn page and have a look at it. It's called Puppet Leadership in Healthcare. And we go through what it is, why it's a problem, how it impacts healthcare, how it impacts everyone else in healthcare, and what can you possibly do in terms of tackling it. Now, this is a topic that I personally have not seen discussed publicly or any public forum until now. So it's a topic that is very significant and quite sensitive, controversial, and it has a lot behind it. So, so keep that in mind, and I ask everyone to obviously be respectful as we go through the conversation. Now, this will not be a formal kind of event. This is a conversation with our faculty, and the audience. Feel free to raise any questions or ask any questions and participate in the discussion at any time if you like. I think you have the power to unmute yourselves and ask questions as well. So, okay, so puppet leadership, well, what is it? It's essentially when leaders get appointed to senior executive positions, not necessarily based on merit, qualifications, or their experience, but based on something else. And that something else is often alignment or loyalty to decision makers of the organization or the system, or the, dare I say, politicians at the top of the system, or whoever is basically running the place, running the show. And it's a form of rewarding that loyalty. So it's what it does is it sidelines those who ask difficult questions. It sidelines those who challenge the status quo. It sidelines those who raise clinical issues over the politics of the day sometimes. And this is why it's a problem. Hence the reason why we raised it here today. So what I might do is I'll start with Liza, you as our first panelist. If you could just talk about your experience with puppet leadership and how you've seen it impact healthcare systems.
Sure. Thanks, Sidney. And hi, everyone. It's great to be here. So to give you a bit more about my background, I've been in the health system for over 35 years, from the frontline services to the boardroom across all sectors in England, Wales, and Australia. So I feel I've got this really unique view of the culture across all of the different systems. And what I've noticed as I've progressed from the frontline upwards, I guess my vision of healthcare leadership was the people at the top are transformational. They're the ones who are courageous leaders, making bold decisions. But what I noticed, the closer that I got to the top, actually, there's a shift from middle management to senior management of being much more about compliance. And obviously, we need that throughout the organization anyway. But I just started to notice the shift of the people who were getting into those senior positions. The people who were agreeable, they were called a safe pair of hands. So whilst on the facade, people would, or even the roles would be advertised, we need somebody, we need a transformational leader. We need someone who's bold, courageous. Look, the system in Australia and the UK right now needs to transform. And in order to do that, we need people who are brave enough to speak out and to challenge. However, when you observe senior leadership, when you get behind the scenes, what you see actually is leadership who plays it safe, who is agreeable. And I notice the closer you get to the government, those relationships are, sorry, can you hear me? Yeah.
Might just ask everyone to mute themselves just in case we get back.
Okay. So what I noticed, the closer you get to those government relationships, the more agreeable that person has to be. And that's often kind of coined as a political appointment. Now, the impact that I see that that has on organizations is a couple of views really. So people who, as they progress through their careers and they feel like they're in the business of healthcare, because if you take that big step back, we are in the business of healthcare. And if that was true, we would have full alignment. We'd have full alignment from the top. We wouldn't have puppet leadership that are being agreeable. We'd have people who are courageous, who are able to call things out, who are able to point out the things that are going wrong and come up with some really good ideas of how to transform things forward. And we don't have that. And when you have people who bump up against that, that causes conflict in the workplace. And then the staff that I've spoken to over the years who've had that conflict really struggle to understand where it's come from. And the harm that can come from that can be pretty devastating. The impact on patient care, again, if we have that big step back and realize we're all in the business of healthcare. As clinicians, we've come into these roles to make a difference, to add value to patients. But if we were really serious about that, then where's the public health part of it? Where's the prevention? Where's the empowerment of patients? Because for me, that's the missing piece. And when you look at the finances and when I've spoke to CEOs, they're more interested in meeting government targets than actually having the common sense approach of, if we want to make this health system work, we've got to empower the patients. We've got to have money put into prevention, and we've got to bring the patient in and walk alongside them. I'll stop there.
So that's a very valid way of looking at things. I think we're always talking the talk about being a patient-centric healthcare system. But you're right, when you go into the back end of how healthcare is conducted, we built ourselves a regulatory compliance mechanism which is set up for and often run by people who are not involved directly with clinical care. And that's, I guess, in a nutshell, you could say that's the frustration with public leadership, isn't it?
It is. And I was just thinking, David, do you remember when we were kind of planning for this talk and you said something really interesting about when you worked at St. Thomas's and the alignment, because I think that's what I'm seeing is that it's not a good or, it's not about judging it to be good or bad. It is what it is. I think we just need transparency because we can't align unless we have that transparency. But David, I'll let you share your thoughts.
Yeah, look, thanks, Liza. Thanks for introducing that. Because I guess when we think about public leadership, we've got a misalignment between the leadership we expect, and that leader may be influenced by external forces, and as they've been brought up, as it might be political, might be financial, in some cases, maybe ideological. And to understand the public leadership and the impact of that, I like the example of St. Thomas's back in 1992. So St. Thomas's, if not everyone may know that, but St. Thomas's Hospital is iconic in London. This is Florence Nightingale's hospital. It's got the original Nightingale wards are still there. It has the Nightingale School of Nursing. And the room where Florence Nightingale used to teach the nurses there, it still exists. It's the Florence Nightingale Museum. It has an iconic place in London. It's on the River Thames, directly opposite the House of Parliament. And if you go back to 1992, we had, I think Margaret Thatcher just moved on. We had John Major, Conservative government. They did have a good plan in that we needed to take, we had too much money, too much healthcare concentrated in London, or the centres of excellence. We had too many centres of excellence. We weren't servicing the population around the country. So the idea was, okay, we've got to consolidate the London hospitals. We've got to put the money out to the periphery. And I think that was, a good idea. And it built on previous structural changes in the NHS building up to that time. But we've got this iconic building, lots of history, lots of love. The staff who work there, it's a home. It was much more than a hospital, much more than a workplace for everyone who's working there. But in order to consolidate the hospitals, the government said, right, the first so many of you who balance your budget, you get to be a fund holding trust, NHS trust. The rest of you, you're being shut. Now, at the beginning of that announcement, my understanding, and don't let truth get in the way of a good story, but St Thomas's was at the back. We were going to get shut. We thought we'd had it. But this is when things align. I think the politicians really didn't want St Thomas's shut, because when they're having a beer on the terrace at House of Parliament, they look across the river. County Hall had already been shut. St Thomas's, iconic hospital, they wouldn't want to shut that. So that's the politics. The finance, the guys who are working in finance within the hospital, they probably wanted their jobs. They probably want success. And again, I didn't talk to the finance guys, but maybe they had an emotional attachment to the organisation, understood the history. Certainly middle management, certainly the nurses, my God, they were up in arms to make this work. And the nurses and the doctors got together. And my experience as I was a junior doctor, then SHO, working in anaesthesia. And one sign of that was the alignment from, let's keep the place open, let's get the finances right, what can everyone do? And the charge nurses in theatre put price lists on all our single-use items. I knew that if I used a 2.5 ml syringe, which is what I'd usually use for a certain job, it would cost 10 times the amount that a 10 ml syringe did. So it went from there, from all the single-use items, right down from a 2.5 ml syringe up to a chest drain pack. And the way that worked, that went throughout the hospital, everyone worked together. Political alignment, financial alignment, management alignment, clinical alignment, and the history of really good care that we were very proud of what we did. And that worked. So that's the opposite of puppet leadership. Everyone aligned. We balanced the budget, became one of the first NHS trusts in London. St Thomas's is still there today. So that's the opposite of puppet leadership. I might leave it there for someone else to jump in.
David, just a quick question on that. So out of interest, how long did that take for that start to finish of that alignment? I'm curious.
Hard to say. I was a junior doctor at the time, and it started. It was just in 1992. It was about a year, I think. Don't quote me on there, but if you look up there's some. I can't tell you exactly, but from my experience, I was only working there for a year at that stage. I've come back in. I started in November 91. I finished in November 92. Within that year, we'd started saving money. We balanced budget. That's my experience of it. But I think if you look up the news articles, I think it might have been a slightly different time frame, but it really wasn't long.
I mean, that's just fantastic, because whenever we think about transformation and having to, change culture in organizations, you often get told it'll take, it take years, if not decades, to turn things around. And what you've described, bringing that organization into alignment and being able to pass that information down to all staff so they could pick up a piece of equipment in theatre and think, actually, I'm going to choose to use this one rather than that, really didn't take that long. And it just makes me wonder, you have these kind of the big five companies that come in and they promise transformation. And let's be honest, if they were going to do that, everything would be solved by now, and it's not in their management model to be able to go in and completely fix things. They need to leave the door open. But what I'm hearing from that example is a fantastic way of how almost like that drive then came from the staff. And it was like from the sort of from the middle of the organization out, or the ground upwards.
Absolutely. There's no way the Nightingales were going to let that place close. Absolutely not.
Yeah. And I wonder as well, whether there has to be, like, sometimes we think about having that common enemy, but actually what you had was that common force for good. It was the Nightingale Hospital, Florence Nightingale. It was too much history wrapped up into it that I can imagine just evoked passion in people to think, not on my watch, is this place going to close?
Yeah, there was no way it's going. And it's slightly different. I can't remember. We did lose some hospitals around London, some of the icons.
Yeah.
We've still got St George's, we've got Guy's, we've got St Thomas's. I'm not sure which other ones survived, but it was really sad to see some of them go. Really iconic organisations that did great work. But on the outside, when they did close, the money went out to the peripheries. For instance, the Medway Hospital out in Kent, that grew and servicing the population of that area. But then I guess there's also, and that was beautiful. I don't know if anyone else has got any other examples of where things have gone well, or I've got a couple of examples where we got the opposite. If happy for me
Yeah,
to
please do share that, because I think what's really helpful is to see the contrast and the damage that's caused when we do have this public leadership in place versus that authentic aligned leadership. And I think, and that's what kind of just brings it to life for us, really. So yeah, please do share.
Look, I mean, there's two things that I could think about. There's one's government-based and one's private sector. And I think because we've talked about political alignment, we talked about financial alignment. And if we look at political alignment, I think it was back in, let's see, I think when was the Bundaberg fiasco? I think it was around 2004, 2005. So we had a lot of very poor outcomes in Bundaberg Hospital up in Queensland, central Queensland. And that triggered a Forster report, which was a real root and branch transformation of Queensland Health. A lot of recommendations went through. The government at the time said, okay, this is not good. We'll activate those. We'll act on those recommendations, and we started building better funded, more staff, better facilities, looking after staff, looking after the patient. That was the idea, and a lot of money was going in. And then we had a change in government around 2012 that really wanted to balance the books. And that's not a bad thing. You've got to, sometimes you do have to trim the public service. And their goal was, well, what we want to do, we also want a better Queensland Health. We want to have shortened waiting lists. We want shortened waiting lists for theatre, shortened waiting lists to see a specialist. We want better care. But they also had balanced the budget. So there's a political force, make it better, but the political force was also, let's balance the budget. So Queensland Health lost 4,500 staff, and half of them were clinical on the frontline workers, and also and we also closed some sites of healthcare, and one of the prominent ones was the Barrett Centre, which was a residential. It was a place where you could have inpatient management for youth with severe mental health. And there were 3 deaths related to that closure, and a subsequent inquiry said this was wrong. We've closed it down. It's wrong. But we've built since then. Queensland Health has made the decision, and the funding has been there to build up the mental health institution. So that's another example where you had people who are working within Queensland Health, management, staff. They want to do the right thing. They want the resources to do the right thing. Want to look after the patients. But it wasn't provided. We had the political and we had the financial imbalance and influence that closed a valuable centre that wasn't looking after people in our community, and awful things happen to people. So that's the flip side when those values do not align.
Yeah, there's a question in the chat about how does public leadership impact on culture. So maybe I can just give my view on that, and then you guys can chip in as well. And Sidney, I can see that you're back, so please add to this. So I think from my perspective, if you strip it right back, because I think there could be lots of examples of how this affects culture. But if we take that big step back, which is what I like to do, and if you think as human beings turning up in an organization, we know when something's not authentic. It's like we pick it up. It's just in the fabric of the whole organization. It's how people show up. It's the language that they use. It's their body language. And we can tell there's something that's not authentic. And over time, that erodes trust. And I think when you start to get into some of those building blocks of what creates psychological safety, sense of, trust, belonging, that authenticity, feeling safe to speak up, if you haven't got that, it just starts to break the culture down, and it just starts to create the rot from the inside out. And that's what can take years to turn that around. So there really is a call for prevention, I think, from this perspective, because if we can get the leadership right, then we know that's going to have an impact on culture. Lewis, you've got your hand up.
Sorry, just before Lewis, can I just add in? And that's actually what I've seen as well, Liza, and especially those people when they see unsuitable individuals being appointed to leadership positions over clinicians or non-clinicians who may be more suitable and appropriate because of the reasons we said, that what that does is that exponentially erodes that trust, and it's just very difficult to come back from. Sorry, Lewis.
I just wanted to throw a few curveballs if I could, because, it sounds like we want the hospitals to be all run by, yes people who just give the clinicians what they want. Just to throw a few curveballs. One, there's plenty of examples of hospitals around the world that have failed miserably in the hands of doctors and nurses who've run them, who are close to clinicians. So I don't think the clinical professions are absent from the risk of being puppet leaders. I'll just make that point. The second is, in other words, it's just not, executives who've got nothing to do with ever being clinical. In fact, I think there's good examples of where puppet leaders have been clinically based for all their lives and then put in that position. The second is there's lots of good examples of non-clinicians running hospitals well. But I think, is it actually less problematic to have a puppet leader than to have a person who is autocratic and won't listen to advice, who's well credentialed but is actually trying to manage their the service in the way they think is best, and is not really acting as a puppet leader? Is a puppet leader actually easier for smart people like yourselves to manipulate into what you want versus the autocratic leader who's in fact pulling the strings?
Well, that's actually a really good point. And but I would challenge you back that it's actually autocratic leadership that is being enforced through the puppet, because it's actually one person or the small groups view, as opposed to taking in the frontline view or engaging with the clinicians and the non-clinicians and applying what they need to apply based on the context, right? They do it for other motives, alternative motives and different agendas. So in a way, that is autocratic leadership. But I take your point. There needs to be a balance. Obviously, we're not talking one or the other. We're talking good leadership. It doesn't matter if it's a clinician or a non-clinician. I don't think that is the factor at all. In fact, I've seen clinicians who are atrocious leaders and should never have been put in those positions without the appropriate training and skills being given to them. So I don't think it's about what profession you come from. It's about having the experience, the knowledge and the qualifications and the characteristics to be a leader that actually integrates the system or the staff. It's not I guess we're saying not a command and control leadership style, but more an integrated leadership style where there's engagement.
Can I just put my last curveball? It sounds a little bit like, isn't this a guaranteed pathway to having nothing left in society money-wise? I can run any business if you say yes to everything I want. And if I said yes to every time a clinician wanted something, and hospitals have example of this, I'd have corridors of useless piece of equipment that they told me would be the game changer in medicine, and a whole pile of computers and IT programs lined up with them that have wasted millions of dollars because I listen to clinicians who sometimes, yes, might have the patient's best interest. Sometimes they've got a lot of their own best interests, publishing, promoting their career, want to be the first person who... I got a message today about some guy down in Victoria who's done the first operation using a single port through a Da Vinci robot. Now, that's lovely. I know how much that robot costs. And there's nothing wrong with using 5 ports to put it into the abdomen instead of 1, and I'm going, well, someone said yes to him, wasn't a puppet, and it's not going to improve an iota of anyone's care. It's going to make him popular because he was on LinkedIn all over the place. So I'm just going to throw, sometimes you need to curtail this whole leadership thing and just bring the clinicians back to ground. But, what would I know?
All right, well, we're going to bring out John. John's got his hand up. He's going to offer a good rebuttal to that. Go ahead, John.
Yes, I am, and thanks for challenging us, Lewis. Unlike you, and thanks for putting this on. It really jumped out at me when I saw it. When I saw the subject, it's not the usual subject that you see, and it spoke to me. So I work in New South Wales in the public system, in one of the largest LHDs. And I led the clinical governance function for the district. So this very much spoke to me. I won't say anything more. But I think to what my response to what you're saying, Lewis, is we can have both. It's not one or the other. We can have both, and I think that's what we're you know, ideally where we can where we could get. I think the product coming from a clinical governance lens and safety one, and I wonder whether this sort of is part of the culture of healthcare, that we've very much got into this compliance top-down approach, at least at the facility level, and I think that that just breeds not only from clinical things, but the way we manage as well. It's very it's very top down. It's very compliance. You know, at the senior level, you butt up against the politics very, very rapidly, and that's and you know, people have spoken about that. In terms of the culture, we're actually going through a little bit of a forced experiment now. Our chief executive has just resigned, so we're in a bit of a holding pattern, and I won't necessarily, you know, his style, and it may well have been impacted from what was above him, or might have been from the people that were below him, but it was very much a compliance, top-down, risk-averse, controlled, button-down culture. Since he's been gone, oh my goodness, are we making hay while the sun shines? The innovation, the breaking down of silos, the conversations that are going on in a very short period of time are amazing. And I think you can talk to clinicians. You can talk to clinicians about finance, as your example from London showed. You can talk to clinicians about dollars, and they understand that. They're pragmatic people. They understand that the stuff doesn't grow on trees. Of course, they're going to want everything, but if you say no, you can't, they actually all will fall in line with that. More than that, if you empower them, and this is what we're trying to do at South East Sydney, if you empower them, they'll not only look after quality and safety for you, but they'll also tell you where the waste is. And I think you can get both. But if it's a top-down puppet approach where the predominant is top-down predominant thing, I think you're in real trouble.
Can I just jump in there? My hand signal on the software doesn't seem to be working. I'm going to challenge you both on this, because I think there's a middle way. I don't think you need either of those leadership, because both of those leadership to me speak of rigidity and not being able to flex and flow. And I think the middle way is having someone who's more like a coach. So somebody who understands the whole nature of the business. They can walk between clinicians and leadership, whether that's a clinician by background or not. It's understanding that there's budgets to balance and having that common sense approach and the courage to say no and the courage to challenge. So I would say, actually, rather than having both, I'd say let's get rid of both. Let's kick them out and actually bring in the middle ground, because in order to where we need to go in the future, that leadership needs to die off. It's old school. It needs to die off. What we need now are the leaders of the future who have got that common sense, because I just feel like they just lack common sense. You know, we've just,
that's the key word. Yeah. Common sense. That is the key.
Yeah, like the UK government now has just decided to kind of get rid of NHS England, which I think is a good move, because there's a lot of bureaucratic noise there and a place where a lot of toxic people get sidelined. And they didn't factor in, I mean, given these people are running the country, they didn't factor in all of the redundancy costs. And they just think, you know, who is making these decisions? There's no common sense. So I'm just going to challenge, there's a middle way. Let's get rid of the other two, kick them out, and let's go for the middle way, which is more coaching, adaptable, can pivot, but is strong, courageous and bold, and can say no to expensive machinery that we might not need.
All right. Well, let's see what the clinicians have to say about this, Mainak.
I was going to jump in along those lines and say, look, I think a lot of health policy is actually based on good clinical fact, and it's done with good intent. So when Dave was talking about his experience in London, what stood out for me was that the Department of Health was clearly thinking about the fact that the regions were not getting enough funding and everything was being sucked up by the centers of excellence in London, and they were trying to spread the limited amount of cash that they had, and this was one way of doing it. There, obviously, when you implement something, there has to be some sort of compliance regulatory culture. You've got to be accountable. So there's nothing particularly wrong with that. But let me give you an example, vaguely subversive, which shows you how things go horribly wrong. So I'm a middle-aged male from the subcontinent, very strong history of heart disease. And if I were to rock up to a local hospital tonight with a heart attack, I would expect to be seen in the emergency department in a relatively quick period of time. I have international guidelines which tell me that really in a hospital that's capable of doing an angiogram in a hurry, my door-to-balloon time should not exceed 90 minutes, and really every 30 minutes add-on time is adding 1% of mortality figures to me. Excellent. We have a College of Emergency Physicians which says urgent cases like heart attacks should be seen within 10 minutes by an experienced doctor looking at the ECG. Excellent. So we've built a clinical standard. Unfortunately, now we have a situation where, without a jot of evidence showing that if the same patient, if I was seen within 9 minutes, I would do much better than if I was seen at 11 minutes. But the system, the regulatory system, will actually accept compliance from a hospital that can see me within the 10 minutes. But for the 11th minute, they will start penalizing the emergency department. And that just makes no sense.
Well, that's when we come back to the common sense approach, Mainak. So, you know, that does not make sense. You're right. But that also implies there are other factors there as well, you know, from a financial perspective, access and patient flow, bed block perspective, etc. So there's all sorts of things that come into it. David, I wonder if you want to comment on that, particularly with your finance hat on.
Well, actually, I'm sorry. I'm really interested in Louisa's comment in the chat about servant leadership. So I could read that out. Servant leadership has a place we can't forget, and as John says, a balance of both. We need to learn from our Royal Commission's recommendations not actioned and coroner's data, and yes to flex and flow. I ask myself, I'm explaining myself to the coroner, privacy commissioner, and or Treasury Finance. So maybe there's one thing is that it's not just finance, political, and so on. There's so many different bodies that we're responsible to within the system. I don't know, Louisa, are you happy to talk on that or just leave your comment there? That's okay. Or has anyone else got anything? But okay, so I'm happy to keep going. Now, remind me, so you were asking me, Sidney, about the finance hat.
Well, what we see commonly is this tension between efficiency / performance / financial sustainability versus quality and safety. That's what we commonly see, right? That is the tension. So just that's what I was wondering your thoughts on that.
Yeah, I think with that, I guess I spend a lot of time with activity-based funding, and I think it's a good tool. It's not perfect yet, but it has done some good things. I think it's put the lid on that exponential growth in healthcare. Exponential growth in the cost of healthcare. It really has driven some efficiencies. People are really motivated to get their admission times and hospital stays down. And we know that's not only does that save money, and it's better for the patients, they get a better outcome, because sitting in hospital for a week after having your gallbladder out isn't good for you. Staying in hospital for a week after having a baby isn't good for you. People generally do better going home. So, but do we have the financial tools to tweak the system in line with the clinic with good clinical outcomes? And we're not there yet. I think there has been some change. You know, the hospital acquired complications, and as Mainak was saying, if you stay a bit longer in, if you get your wait time in emergency longer, you're penalised for that. And I think there needs to be more carrots and less stick, and really for the economists to sit down with the clinicians and with the managers and to work out, well, here's the funding tools we've got, which ones are really going to drive improvements in care. Does that resonate with what you're asking?
In a lot of ways, what you're saying is the way that we've structured the system, particularly our funding structures, is setting up the structure for puppet leadership. It's actually enabling it. It's incentivizing it because there's an inherent tension. But for example, if we were to, fund based on patient outcomes instead of activity or volumes, then we're aligning those incentives. So really that tension would not exist theoretically.
Yeah, and that's very difficult. I think aligning with patient outcomes is fantastic. And then, we're looking at that whole value-based healthcare model, just those four things. Two very important things is your patient outcome, patient experience. But then also we've got to look at the culturally diverse nature we have in Australia. So we're kind of getting away from public leadership here, but it's really hard to get that model right. For instance, we know in our First Nations communities, a good outcome isn't the same as a well-paid lawyer in Sydney. That there's very different attitudes to healthcare and what does a good outcome look like, and what do we have? What mechanisms do we have? And I'm just wondering if anyone's got a favourite mechanism in healthcare funding from their work that they think works very well. Are they seeing anything that's good?
Just before we go too much down the funding rabbit hole, can I just bring it back to the puppet leadership? We've just got 15 minutes, which means we've had 15 minutes to come up with the solutions. So what is the answer to this? What do we advise, or what should healthcare leaders do when they see puppet leadership in their workplaces? How should they tackle it? Liza?
Okay, so I'm happy just to I'll lead into that, but there was something I wanted to say that's going to kind of bridge into it. So I think what we're starting to kind of understand, and it's becoming very clear from this conversation, we have many masters to serve within healthcare. And when you're in healthcare leadership, you've got these many masters to satisfy. So at the core of our work, values-based healthcare, it should be clinical decisionally led and patient-led. How can we bring more of the patient voice, the family voice, people with lived experience, so they sit alongside us? It's not tokenistic, but it helps to drive. Are we actually giving patients what they want? Or are we giving them what we think they want? And then when we try to balance the nature of our business versus the many masters that we're serving, and some of those are very political, for me, what makes common sense is, if we're being, and I think, Sidney, you posted about this in the last couple of days, if we're being asked to do something, we have to have the courage to say, if you want us to do X, we can't do Z. What's the priority? And I think we're lacking that kind of transparency and those types of conversations at that senior table. Because if you've got the puppet leadership who's agreeing, I think what you end up finding is that they're agreeing to all these masters, but they can't deliver on all of them. But if you give that challenge, then you're going to be seen as being disagreeable. You're going to be seen as going against the grain. And that's not what the masters want. So I just wanted to kind of just bring that out, almost as a summary of what I'm hearing from today, just to bring that transparency to the table. So I guess in terms of what I would say in terms of solution, I think first to understand the transparency. Again, puppet leadership, it's not about being judgmental about it. It is what it is. But if we're transparent, then we can understand the powers that the puppet leadership are serving. And that in itself, I think, just can unlock a huge amount within the system that can help us, because then we have an understanding of the playing field that we're in. Otherwise, we're expecting to be doing something, but actually the game behind the scenes is something completely different. So for me, the call is transparency and the middle ground in terms of the leadership approach.
That's good. Thank you, Liza. But I have a question back for you. So I guess the challenge is transparency or authenticity in cultures where puppet leadership is already set up, because if we question the status quo, then, well, you won't be getting the next promotion into that senior leadership role, right? So that's what we're struggling with. But no, I absolutely acknowledge what you're saying. John?
Cool.
Sidney, I thought you were going to give us the solutions rather than asking us what the solutions were. That's why I came.
Come
But anyway,
come on.
That's where puppet leadership starts, John.
Wait for
There's a round
the
table.
next
Round table,
post,
John.
John. I'll wait for the next post. I'll list them for you. Solution 1, solution 2.
well, look, I'll give you I'll give you a start, and look, I think it's some of the things that Liza said. I mean, we need to be in the tent. We need to be in tent. It can be very easy to get frustrated and pissed off, and then leave. So we need to be in the tent. We need to be patient-centered. I think it's very hard for people to when you put a patient-centered argument forward, it's very hard wherever anyone is in the hierarchy to argue with that. And as clinicians, we can put the patient-centered argument very, very easily, and we need to advocate for them, and we can do that. And then I think we need to be clever with the puppet leaders and show them, rather than work with them, rather than challenge them, because we know what they'll do. They're all control freaks and they like to be in control. We need to work with them and show them how we can help them achieve their aims by shifting this way a little bit. And that's the beginning. That's the beginning, I guess, of maybe getting some changes here.
Yep, I think that's absolutely right. And perhaps also when we're emphasizing the clinical side of things, clinical safety, trying to equate that to the financial consequences if it's not adhered to, that would resonate with people who are driven by financial policy, I think. All right. Anyone else got any suggestions, solutions?
I was going to say that the problem is the system. Puppet leaders thrive in a command and control system. But at the end of the day, as clinicians, it's very common to go into a tea room and hear about the dysfunction in the healthcare system. But at the end of the day, there's no such thing as a dysfunctional system. They're all designed to deliver exactly what they do deliver. And unfortunately, we have migrated to a very command and control type of situation where it's less about what the patient needs and more about what we say we're going to give them in some ways. And then we create a surrogate regulatory regime, which is predominantly stick and very little carrot. I don't know. I don't know that we can change it overnight, but perhaps changing organizational culture is a difficult thing. But that's, at the end of the day, that's what we need. We need our leadership to collaborate. I have no expectation that I will get every shiny toy that I want. But if we can both talk in terms of what the patient's needs are and go from there, that might be a good start.
Yeah, and I think the transparency there is willing to, you can say no to certain decisions, but be willing to explain the rationale as to why. And I think that is where that authenticity and transparency comes from, perhaps. Okay, we've got a few hands up. I don't know who was first.
I think Lewis before me, and was there anyone else?
One thing I think matters is our own personal responsibility, taking on John's comment about being in the tent. We need to be in the tent, as John said, in my view, and we need to know what we're talking about, and it's not just about the clinical side. I do feel many times we let ourselves down as clinicians by focusing on the patient will die scenario, or I'm the clinician. In fact, I teach that if anyone in a meeting says I'm a clinician, or as a clinician, you can turn off, because they're going to give me some sort of thing that I'm probably not going to understand to justify, where I would rather them go, we're all working together. I know your pressures. I know actually how to help. Someone who's actually presenting solutions rather than giving me more problems is going to be heard much better by me. You can call me a puppet leader, or an old-fashioned leader, or a dictatorial leader. At the end of the day, I don't need as many problems on my head that I have. And clinicians coming forth with solutions with their questions are going to get heard. And that's about developing our skills. If you don't understand how to read a cost center report, you got to go and learn. If you don't understand what clinical service planning is about, you got to go and learn. You can't be part of the management and the leadership in healthcare by just being good at what you do in one part. I think all clinicians in leadership roles should consider themselves healthcare leaders first, clinician and specialist second, and learning, whether you go off and learn it on your own, you do courses we have, whatever it is. And I'm not plugging us, I'm just saying you've got to take responsibility for that. It can't just be complaining and not having solutions.
Yeah, absolutely. And I'll take that opportunity for some shameless self-promotion here. We do have those courses, so feel free to sign up and come to those if you want to read a cost center report. David, I'll hand over to you.
Yeah, thanks. Look, great discussion tonight. I've really enjoyed this, but I just have to back up John and Lewis. So you've got to be in the tent. We've got to have those discussions. And really, I think what Lewis was saying, you've got to work on ourselves. So we've got to understand the environment we're working in. We've got to understand our own communication skills. We've got to understand who the key players are in the organisation and how to communicate to them in their particular communication style in order to influence them towards better care and to get everyone aligned. So I think really just backing up what John and Lewis were saying there. Well, actually,
So are you saying that we've got to learn to play the game? Is that what you're saying?
Oh, that's certainly a big part of it. Sometimes you can't.
Lewis and and John, is that what you guys are saying by being in the tent?
I think before you said, my understanding was it means you've got to be there, you've got to be talking.
Yes, I just put my answer in the chat.
And
Yes,
be better at it.
better at it.
Yeah.
Sorry, David, keep going.
Yeah, no, I've just got one thing. I was chatting to a good friend of mine today she's the CEO of OneBridge. I do a little bit of clinical governance work for them, and they provide healthcare to vulnerable communities. And Sonny's just finished that Churchill Fellow, and she started this business, and things are going well. They're really starting to work. And it's an organisation that I love working with, great team, great mission. And but what sometimes bad leadership or puppet leadership is going to get to you, and it's going to give you the shits. And I've allowed myself to get angry and to be reactive. And we mustn't be reactive. We must be responsive. And that is so hard to do. But what Sonia said, she said, when the shit hits the fan, be the weather, not the thermometer. And I thought, so be calm, put some calm weather around this, chill, sit back. And the other thing she said was to think, don't get sucked into the storm. And she said to think risk, think governance, think reputation, think self-care, but above all, this has to lead back to care of the patient and care of the community. And so that just really resonated with me. And I think those are the things. It is working on ourselves, knowing who we are, who we're working with, what is the environment we're within. I hope that resonates. And I hope that's useful.
No, thank you. And just before we close off, can we just quickly explore the concept of managing up? Because that is something that is often taught in healthcare leadership training, which could, really lead to puppet leadership as an unanticipated consequence, really. And the concept of speaking truth to power, because that is something that's what it comes down to. If you see decisions being made that are harming patients or are not having the intended consequences, then how do you speak up? How do you challenge respectfully whilst being in the tent? Lewis, you seem to be very opinionated on this. What's your solution?
I firmly believe if you want the respect and to be heard by puppet leaders, you've got to protect them a little bit from themselves. and also from what's going around. So I actually like making sure that I treat the boss above me the way I hope that people would treat me, is to make sure that unnecessary embarrassment or things I should know, that I'm not left out of the loop. Because at the end of the day, even if you don't like me, if I don't know what's going on, I can't help, I can't react, and then you should tell me what I should do about it. So I therefore play the same thing, even with a puppet leader. This is the problem. This is what's going to cause you yourself reputationally. I often say that, and a system. And this is what I suggest we should do. If they do it or not, sometimes it doesn't work. The last thing I'd say in this regard is that, and listening today, I think we should all be conscious that I'm sure at times we could do two things. I'm certainly guilty of one. That comment that you said, David, is going to resonate with me. I've been too often the thermometer. I've let the Spanish blood come to the top, particularly with the whole patient-centric and, oh my God, the patient's going to be harmed because of our stupidity approach. It does wear thin at times. The calm, considered approach, which is what I try to teach, is far more powerful. That's the first comment. The second is that we can all, if we're honest with each other, probably sometimes exhibit puppet leadership traits ourselves. A lot of us have ego, maybe none of you, I certainly do. A lot of us want to be successful, maybe none of you, but I certainly do. And a lot of us want, I've already had my career, but if I was your age, all of you, I'd be probably thinking, how I can rule the world. And therefore, at times, we might be a bit complacent in that regard and a bit malleable to the strings being pulled ourselves. Just saying, I'm sure no one on the line here, but maybe some of your friends need to be hearing that.
Well said, well said. Liza?
Yeah, just to kind of finish off on speaking truth to power and managing up. I think there's two sides of that I've seen. Sometimes I've seen the managing up as literally just like blowing smoke up someone's butt, excuse the French. But just being like this limp lettuce person of just coming across as so inauthentic and just almost like fawning over what they're saying and constantly agreeing with them. And then I think when it comes to speaking truth to power, sometimes that can come across as quite harsh and quite combative. I think the middle ground to that is our opportunity. And I think John mentioned it earlier. So we do have an opportunity to, one, be in the tent. We also have an opportunity as to how we speak up and what language that we use. And I saw somebody who taught me this quite some years ago, and she was an expert at giving feedback. And the opening is, are you open to some feedback? And very few people are going to turn around and say, no, I'm not open to feedback, because you have to be seen to be open to feedback. And sometimes we lack the opening sentence to drop the bomb. So I think having that soft opening of, are you open to some feedback on that? And then being able to put across what we want to do to challenge, I think comes across quite well as well when we're speaking truth to power. Because when it's the other way around, it's flimsy, it's inauthentic, and it's just, it's just really frustrating. That's what gets me frustrated when you see people managing up.
Yes, and I guess it's coming across as confrontational and setting up an antagonistic atmosphere right from the start, which is not, which makes them more closed off to hearing any feedback, I suppose.
Yeah.
Does anyone else have any final thoughts or pearls of wisdom they want to share with everyone? No? Well, look, we'll continue these sort of conversations. I think the first step is having forums like this where we can at least explore these concepts, because this is the first time, as I said, I have seen this concept explored in a public forum. So thank you all for joining in and participating. This has been really enjoyable, and I've loved the conversation. And if you have any questions or thoughts afterwards, feel free to reach us through our email address, which is inquiries@aihexec.com, or direct message us on LinkedIn as well. So until next time, thank you, everyone. We hope you have a good evening, and we hope you got something out of this, at the very least, an hour of enjoyment. Good night, everyone.
Thanks, everyone. Really enjoyed it.
Thank you.
Thanks. Bye.
Thanks.